I'm Zvonomir Krajcer. I'm an interventional cardiologist at Texas Heart Institute and Baylor CHI's Medical Center in Houston, Texas. The topic of my presentation is VenaSil, concepts, tips, and tricks for treatment of chronic venous insufficiency. Here we have a list of the disadvantages of thermal ablation therapies that have been very popular for the last several decades. One of the most important one is that thermal ablation therapies cannot treat all venous segments due to potential nerve damage, which is particularly of concern below the knee. There is also potential risk of skin burn and stain in superficial suprafascial veins. And they all require tumescent anesthesia that carries certain consequences such as bruising, some patient discomfort, and requires post-procedural compression hose for an extended period of time, which is limiting in warm climates and difficult for some patients, particularly for patients with a critical limb ischemia and extensive peripheral arterial disease of the lower extremities. So non-tumescent, non-thermal therapies have evolved to lessen or eliminate the risk of thermal ablation therapies. They require less needle sticks, no sedation is needed, no tumescent anesthesia is needed, and this modality can also treat suprafascial saphenous veins and can also treat the whole saphenous vein segment from the ankle all the way to the saphenofemoral junction, and we can definitely avoid nerve damage since it's not thermal. It also lessens procedural and also post-procedural discomfort. There is definitely less bruising and less bleeding that occurs with the procedure, and it's also minimally invasive treatment modality. The procedure can be safely done on outpatient basis in a physician's office under local anesthesia via endovascular approach, and here we can see a standard setup for this particular procedure. The important thing is, similar like with thermal therapies, you have to mark the entry point of the saphenous vein and also determine where is the most appropriate position to enter the vein. Here is an example of a 27-year-old patient with a history of left lower extremity DVT, with a history also of May-Turner syndrome, status post previous iliac artery stenting. She continued to have significant insufficiency of the greatest and lesser saphenous vein of both lower extremities. And you can see with the procedure, there's only a need for one Band-Aid and no need for elastic stockings. So what does procedure of a VenaSil closure system looks like? Well, we use a cyanoacrylate adhesive that comes in a 5mm vial, and it also comes with a catheter and a handheld gun. It is indicated for permanent closure of the lower extremity superficial truncal veins. The substance is not mutagenic, it's not pyrogenic, it's non-hemolytic or cryotoxic. It can also can be used and is frequently used for intracranial arteriovenous malformations, patients with GI bleeding due to vascular issues, for tumors, genitourinary abnormalities, and also post-EVAR for treatment of type 2 endoleaks. As we can see here, the presentation of the procedure using VenaSil closure system, which is a non-tumescent, non-thermal, non-sclerosant therapy for venous reflex, consists of entering into the vein with a needle, a wire, and then a catheter that's proprietary for this procedure, and then injection by a gun of 0.1 cc of cyanoacrylate in 3 centimeter segments, and external compression of the vein by a sonographer during the procedure that activates cyanoacrylate and stimulates progressive closure of the vein that is being treated, as shown in schematic representation here. So 30-second compression is needed after first Venasil injection is given, and this substance rapidly polymerizes and encapsulates the vein and causes fibrotic tissue to form throughout the length of the vein. And you can see the catheter is removed and one stereostip is placed at the end of the procedure. So what are the results of Venasil procedure in comparison with radiofrequency ablation and the use of polydecanol in the form of MOCA or Verthina? We can see that in two studies, eScope and VCLOSE studies, the success rate was very high. At 12 months, 94%, and 94% also at 36 months. And in VCLOSE, the Venasil study, the success rate was even higher. At 12 months, 99%, and 94% at 36 months, which appears to be as good or even better than with other therapies mentioned above. In conclusion, Venasil therapy has evolved to lessen or eliminate the risk of thermal ablation therapies. It requires no sedation, less needle sticks are required, there is no need for tumescent anesthesia. It can treat also suprafascial truncal veins, and you can treat the whole vein from the ankle all the way to the saphenofemoral junction for greater saphenous vein, or from the ankle to the popliteal junction in the lesser saphenous vein. It definitely avoids nerve damage. It lessens significantly procedural and post-procedural discomfort and offers less bruising and less bleeding post-procedure. So, are there any downsides to Venasil therapy? In my personal experience, there are very few disadvantages or downsides. We occasionally see, as we can see here, minimal redness at the site of ablation procedure with Venasil. It causes occasional redness or allergy to cyanoacrylate or minimal thrombophlebitis. This typically resolves promptly with the use of anti-inflammatory oral agents and also with Benadryl, and does not require treatment with antibiotics or any anticoagulants. Thank you very much for your attention.
Thank you. So, Dr. Patel, so now we'll have 10 minutes for the Q&A, and I would like you to actually take over the proceedings.